Good morning, everyone. I guess we'll get going at the 10 o'clock hour. I appreciate everybody coming today. My name is Brad Cherry. I'm an LPC and an LPCC in the state of New Mexico. And I'll tell you a little bit about myself in just a minute. But today they said, talk about mental health and substance abuse. And I said, I'm going to talk about that, but I'm really going to talk about trauma. So we're going to really talk about trauma and some aspects of how we see that play out with substance abuse and mental health. But I'll tell you why trauma is so near and dear to my heart and how it kind of came through to me through my career a bit. And I'm sure everybody in this room, in one way or another, whether professionally or personally or both, has experienced trauma at some level throughout their lives. And the clients we work with and the society we live in, unfortunately, in some aspects. Okay? So why is this important to me, my different roles? So I started out about 16 years ago, right out of undergrad, and as many of us had, and I went and kind of worked, it's called a youth counselor, essentially it was a tech. And I work with juvenile boys in the Philadelphia area, north of Philadelphia, who generally are from that area, Philadelphia and the surrounding counties, who had problematic sexual behaviors and were sent there by the court. Of course, those crimes are pretty egregious in our society, the way it's looked at, but we saw a lot of trauma. Now, of course, it didn't click with me then about what was going on, but I certainly heard a lot of stories and saw a lot of things and reports, and others, the door's locked, thank you. So I was dipping my toes into the first aspects of like what trauma is and how it plays out. But I really didn't see the long game at that point, being like a 22-year-old young guy. I worked there for several years. I kind of moved into some like operational roles, like administrative roles, different things along there. Kind of saw the bigger scheme of things, how things worked in the court systems, with children, with adolescents, with parents and adolescents, and those relationships. Then I said, I need to get some clinical training. So I went and became a therapist. So I studied while continuing to work in that kind of operations role, and then, of course, gain knowledge and understanding about where some of this trauma might be coming from and how this plays out. Again, still not real aware of ACEs, but it was certainly something that, as I look back, was there and present, and we'll talk about ACEs as we go through this presentation. So I became a clinical therapist. Again, this is in Pennsylvania. I am licensed in Pennsylvania, LPC in Texas, Pennsylvania, and I'm LPCC in New Mexico. And that's just a part of moving around with family and different things. So I hold all three of those licenses. I do telehealth for different organizations like Teladoc, so I can keep my feet on the ground with individuals. But currently, I'm the lead clinician at Assertive Community Treatment for Peak Behavioral Health here in Las Cruces. For the serious mentally ill, individuals who have struggled with consistent hospitalizations, serious substance abuse disorders. You know, we're talking about three major diagnoses: bipolar, schizophrenia, and schizoaffective, and the things that go along with that. So you kind of can see my continuum of working in these different roles. Now let's talk about those environments, okay? So children and adolescents, so I got to see kids, 12 and up, early on, what that looked like for them, what the trauma, how it played out, what the behaviors played out. Then I kind of move into the abuse side and then the victim side. So I did groups for children who experienced severe trauma in Philadelphia, sexual abuse and other. So I saw the offender side and I saw the victim side, but the traumas pretty similar, unfortunately. Then I worked with lots of adults with criminal records. Again, the trauma was ever present and consistent. So I had the outpatient role, the residential role, where kids would live there 18 to 24 months, the inpatient role, where I worked in the hospital in Peak, as well as a lead clinician, helping individuals with serious mental illness as well, and the incarcerated. I worked in a prison as well. So the reason I'm laying this out is just kind of show you that continuum of care. I had the experience all the way from outpatient, all the way through incarceration, everything in between, from acute care, and now with the ACT team, which is kind of a really cool idea. I'm not sure how familiar you are. There's a Fidelity model from California to New York, Minnesota to Texas, where we really try to treat individuals who have serious mental illness in the community where they're at and prevent them from going into inpatient hospitalization and incarceration. But the trauma is always there. So the intersection of this idea of these childhood traumas and how it plays out in adulthood and adolescence, okay? And the outcomes we see, one way or the other. So what are the big things? To witness the impact of trauma on youth, witness the impact of trauma on adults, and then how profound these outcomes are over a lifetime and consistent they are. We talk about trauma, we talk about a whole person, what that means to them in their life. So the resulting rates of substance abuse and mental health are significant. And we'll get into some of the details. So today's going to be a little bit of a macro overview of it. We'll talk a little bit about the interventions we can put in. But my kind of crusade over the past couple of years has been really getting this idea of how trauma plays out in individuals' lives, from childhood through adolescence through adulthood. So this is chess, not checkers, guys. We got to play the long game. So we can do immediate interventions. We can fix the problem right in the moment. We can get somebody housing. We can get somebody, a meal. But it's going to be the same problem next week or 2 weeks or 4 months or whatever the case might be. And that's good stuff. Don't get me wrong. We need to fix that stuff. But we have to look at trauma as ongoing and intensive and how we can treat that so we can lower those instances of need and help these individuals. So I'm very much with the long game idea. So what are these adverse childhood experiences I'm talking about? So this is from the Adverse Childhood Experiences Study. Something happens between infancy and adulthood to create a lifetime of addictions, abuse, and mental health problems. Let's keep it real simple. That's the definition we're going to use today, okay? And that's what's used for the CDC as well. Pretty broad, right? But it's meaningful, unfortunately. So we use that term because there is no single best term. You hear different terms. You hear about narratives, adverse childhood narratives or narratives of abuse. The cool thing or the important thing to kind of recognize is that these studies have been replicated. The same results keep coming out from the trauma and how we see mental health play out and how we see substance abuse play out, how we see generational trauma play out. So it's real, it's replicated, and it's present everywhere. So again, we all know what trauma is. We have an idea, but just for our purposes today. So obviously the direct experience of trauma, right? You're in the car, you get T-bone, mom dies, right? We call that a big T, major trauma, right? Big T. Witnessing traumatic events in person, domestic violence, drug overdose, right? Those type of things, shooting on the street, okay? Maybe some of those are smaller traumas, like ever work with kids and they talk about coming home in the afternoon and they're just terrified if dad's going to be there? Because what that means for that night, because he's an alcoholic, or is he going to hurt mom? Those are little traumas, little T's. So our big T's can be significant and they cause lifelong trauma, but those little T's can add up. It's synergistic, it's additive, right? So maybe a kid doesn't have a huge experience of some significant traumatic event, but he talks about consistent poverty, right? And likely with consistent poverty, you're going to see something that's pretty significant anyway, right? But these things add up, and I think that's important. I want you, if you try to get a takeaway today, they're not cordoned off, okay? They're not boundaried off. They add into the experience of trauma, and by relation, the experience of mental health and the experience of substance abuse. Learning that a traumatic event occurred to a close family member, of course, or a close friend. I was recently involved doing an assessment on a client, and he talked about when he was 13, he's in his 50s now, 50s, 60s. He was walking down the street and a stray bullet hit his friend when they were 12. That still sticks with him. That still is very present in his life and the choices he makes, okay? So that's an example. And then experiences firsthand repeated or extreme exposure to adversive details of the traumatic event. So that's the triggering stuff, right? And then there's vicarious trauma, but that's for us. We'll talk about that in a different training. Okay. So for youth, when we talk about what leads to some mental health problems when regards to trauma, we're talking about sexual and physical abuse, right? Sometimes I think people who aren't real deep in the field, they forget about neglect, right? Lack of support, lack of education, lack of resources, not knowing what you're going to get that night to eat. Those are the little T's that add up. So neglect is certainly a part of trauma, and it's ever present, and it leads for a long time. I know I was in a couple presentations yesterday, and they were kind of breezed about, their goals were different, but they would mention adverse childhood experiences. And this is kind of coalescing that a little bit today for everybody. So again, a severe one-time or repeated event. So yes, even just once can cause serious trauma. Actions perpetrated by someone known. And this is the reality, if you work in this field long enough, the majority of these traumatic events are done or experienced by children or adults, by people they know, maybe people they care about, people they love. And in a way, that's more traumatic because you're supposed to be able to trust that person, be engaged with that person, and they're betraying you, and that's fearful. And it talks about different attachment styles. And that plays into that as well. We had one of the presentations were on attachment styles yesterday. But a lot of trauma is committed by the best friend, the neighbor, the dad, the mom, the uncle, the cousin. I mean, you guys name it. That's who has access to our children, our adolescents, and our adults. And those are the ones who create a lot of trauma. We worry about the stranger danger, right? The weird guy in the alley. The data doesn't so much support that. Particularly when we talk about sexual offenses, but most offenses. We talk about gangs, that's a different story. So when gang violence is a little bit different, but that trauma is very real as well. So intentional, repeated, and prolonged, right? Those are the ones that are most significant and most ingrained in individuals and the most impactful over time. So what are some of these symptomologies, right? So disassociation, right? That gets complicated for a lot of people, whether you're in a clinical setting, what that means. We're not going to get into that today, but individuals do experience that. Flashbacks, nightmares, these are all re-triggering, okay? When we talk about flashbacks, it's not a memory, okay? We're talking about an experience of re-experiencing the event. So those physiological experiences that happen at the time of that event is reoccurring at that flashback, right? That's why you'll see the sweating, you'll see the nervousness, you'll see the agitation, the pacing, right? The disassociation. So that's important to remember when individuals who have trauma talk about those re-experiences or those flashbacks, it's as if it's happened again in some ways, and that trigger and trauma is there, okay? Hypervigilance, this means I have some clients who won't put their back to the room. They have to sit by the wall. Why is that? They're afraid they get hurt, okay? They have to be hypervigilant at all times. Are they safe, right? Can they keep themselves safe? Imagine that level of stress of always having to wonder, am I physically safe in my environment? Am I emotionally safe in my environment? It's taxing. Can you do homework that night if you're worried you're going to be safe? Probably not. You can be able to take a test? You may fail it, but you might be able to take it. It's exhausting. Survival is the number one thing, right? So the fight, flight, or freeze comes in. So if you're hypervigilant all the time, that's the goal, to keep yourself safe. So everything else goes away. What happens? Well, why'd you fail the test, Anthony, right? Why aren't you doing better in school? Why aren't you playing soccer? All these things. So it gets very confusing when we kind of get underneath these issues. We see what's really coming from this stuff. So they experience terror. You hear about night terrors. Anxiety. Anybody have anxiety in here? And we don't have to answer. We all experience it. Somebody, there's just stress, right? Coming into them thinking, I got to do a presentation. That's a little anxiety producing, maybe, right? But this level of anxiety becomes impactful on your daily experience. Maybe you start taking a drink, alcohol here and there, right? Maybe you start smoking joints more and more. Maybe you do something else that's unhealthy, right? Maybe you gamble a little bit, right? Maybe you have unprotected impromptu sex with people, right? These behaviors start developing, right? And if there's a penchant or a genetic predisposition, which we know can be there for depression, it starts playing into that, right? So these are how these things kind of snowball. So you may have a 10-year-old kid, Billy, who has an experience of somebody dying close to him unexpectedly, and this creates anxiety. This anxiety plays into coping mechanisms when he's in early teens, right? Then he starts drinking, and then he gets into a gang, and then he sees drugs, right? And then we see the snowball. Then the depression gets more intense. Maybe bipolar disorder develops depending on how that plays out for him, so on and so forth. So we're talking about the intergenerational experiences of trauma and serious mental illness and substance abuse as well. This is from a much longer presentation, so I'm going to do my darndest to just keep us to 45 minutes today, guys. So I'm going to do my best. Again, people numb out. You ever see the numbed out patient, the numbed out client, the numbed out kid? Everything just kind of bounces off of them. The eyes just kind of aren't there. We have to re-engage them. We'll talk about that, but we see that a lot. Self-injury, high in our female population. I'm seeing it more and more in our males as well, just in my own personal experience. Eating problems, and then, of course, poor judgment and continued cycle of victimization. So when you're in these cycles, you pick poor environments to be in, around poor people to be in, and these continues and so on and so forth. And, of course, aggression. And if people's coping skill is aggression, where do they end up? Prison and jail. They tend to be, right? So that's part of the issues. So these are symptoms, not necessarily all pathology, but they're survival strategies, all right? So we see a 12-year-old or 20-year-old, and it's a lot harder to see the adult that way if he's hurt somebody, right? Hurt the community, and I get that. we see these behaviors, if we really want to get underneath of it, we got to start looking further. Chess, not checkers. So usually in my longer presentation, I would show this. This is an amazing lady, Dr. Nadine Burke-Harris. She's a pediatrician, brilliant pediatrician, which is also a trained public health individual. I think she has her master's degree from like Harvard or something in public health. And she does a really good presentation. It's a TED Talk, actually. But she's talking about the first ACEs study. And what it was between the CDC and Kaiser Permanente. And they started looking at trauma. And I have some paperwork here for you. It's stuff that was getting thrown out in the recycle, so I grabbed it so we could reuse it. So I'm not killing too much paper. But basically what she's talking about is her experience as a pediatrician in a very poor neighborhood in San Francisco, as if that exists, right? But apparently it does. So she went to be a pediatrician. She got out of medical school, I think. She did medical school, then she finished her public health degree, and she went to be a pediatrician. There was only one pediatrician. I think it was near like a public housing issue, thousands of people, a large city. And there was like something like 12,000 kids there. So she went to work, practiced there, and she kept writing scripts for Ritalin and Adderall. She kept seeing these impulsivity issues, can't concentrate, can't sleep, all these different things. And she kept writing these scripts, and she kept saying to herself, like, what's going on here? And one of her colleagues comes in, and he puts the study on our desk that came out from the CDC and Kaiser Permanente on aversive experiences for children. And she read it, and she said, damn, this is what's going on every day. I'm seeing a kid or two like this. And she says, we have to fix that. And one of the analogies she uses as a public health professional, I think it's really clean and really straightforward, is if there's a well and there's a village and all the kids drinking out of the well, 100 of them, and 98 get diarrhea, do you write 98 scripts for antibiotics or do you fix the well, right? And that's her point here, and she's a pretty brilliant lady. She's continued to do all this work. So I encourage you to check this out. I'm not going to show you today, but that's the idea of ACEs. So we see trauma, right? Then we see the substance abuse, we see the mental health. So we can work on the mental health, which is great, which we want to do. We want to work on the substance abuse, which is great, and we want to do that. But if we fix some of the trauma stuff, we're going to see less of the other stuff. And that's her point, which I think was pretty cool. So what does this ACE study tell us? And this is the original study. So about 17,000 different interviews or ACEs assessments were completed. 1/4 grew up with an alcoholic or a drug user in their home, right? 25%. So we know what that looks like, right? When the parent's alcoholic or drug user in the home day after day, the impact on kids when we see those outcomes. And we'll talk about that too. Physical abuse rampant, 1 out of 4, okay? So if I brought you 4 kids from a local school here, or any school, maybe one of them is being abused or has been abused physically. 2/3 had 1 adverse childhood event. And we'll talk about what those 10 different things are. That means 66% experienced 1 adverse experience as a child. Again, children are resilient, don't get me wrong. We can overcome this stuff, but it's profound what we're seeing with some of this data. And 1 in 6 had more than 4 ACEs out of 10. And the cutoff for 4 is because we see a significant increase in negative outcomes when people have 4 adverse experiences, adverse childhood experiences. We see substance abuse go through the roof. We see mental health go through the roof. Any questions? You guys doing okay? All right, cool. So compared with people with no ACEs, those with 4 or more ACEs, and here we'll go into some of these details, twice as likely to smoke. Smoking's like, it's not good. We all know it's not good. What does that really mean? Well, if we really look at it, it means COPD. It means asthma exasperation, right? It means early death. It means more money to buy the Newports or the Marlboros or whatever they're buying. It has significant implications over a lifetime, right? Why do people smoke? Well, a lot of for them, it's a trauma response. It's how do I manage my anxiety, right? 7 times to be alcoholics. Alcohol kills. Liver, kidneys, heart. They do it long enough of it, they're going to have hypertension, they're going to have COPD, they're going to have pulmonary issues, they're going to have heart failure. It's significant. So we're not just talking about mental trauma outcomes. We're talking about literally people's lifespans, their health outcomes. So when we can intervene with the mental health stuff early on, get them on the right track, we can literally save their lives in the long term. Like, here we go, choices likely to have cancer, heart disease, early sex, age 15, we know what the outcomes for premature sex, right? Although some of the rates are getting better nationally. 12 times more likely to attempt suicide. 12 times, okay? That's significant. And then men with 6 or more ACEs, so that's really significant, right? 6. 40, it's like just a crazy number, right? 46 times more likely to have injected drugs than men with no history, right? We know once you start injecting drugs, what those outcomes look like. Not good, okay? So we talk about a dose response relationship. How much and how much we get out the other end. So the more trauma, the more we're going to get negative on the other side, okay? So we went through these a little bit here, the different experiences, but I just like that top piece there from the slide I used before. Dose response, remember that idea, dose response. So one traumatic event is going to be impactful, but say it's a kid in a very well-adjusted family and something terrible happens, dad dies, drops from a heart attack playing basketball, it's going to be significant for him. But it's a kid who experiences significant trauma over a long term, over and over again, it's going to be very different for that kid, okay? Dose response relationship. So just has some data, and I try to keep it pretty straightforward, a couple of these slides. So ACEs prevalence of abuse and neglect in the original study. So of women, we see physical abuse, 27%, okay? Sexual abuse, 25%, and emotional abuse, 13.1%. With men, we see physical abuse even a little higher, right? Almost 30%. Sexual abuse, 16%. Do you think men and boys are always really honest about sexual abuse now? So my guess would be that number's higher. Probably closer to the female number, okay? The general rule of thumb is to say 1 in 4 females experience something inappropriate between 1 and 18. The internet's kind of increased that in different ways, and they say 1 in 6 boys. I would say it's probably more like 1 in 5 boys, but that's just me and my experiences. So don't take it as a CDC or anything. Neglect, so again, I talked about neglect earlier, and I think sometimes this is the forgotten part of trauma. See those numbers, 16.7% for emotional neglect and 9% for physical neglect. I guess that's got to be higher, but that's what the numbers they're presenting. And then for men, 12 and 10% respectively. Anything surprise you about these numbers? Okay. So household dysfunction, and this is so important because the way the household runs really dictates some children outcomes as adults. I've said this many times, and I'll continue to say it until I'm blue in the face. One of the biggest lotteries we'll ever win in life is who our parents are. It makes a big difference, okay? Not that a dysfunctional family can't be overcome, because it is, and it does. But it really does have a large impact on the substance abuse use, on the mental health issues that come out. So for men and women, there's about a 5% difference, 6% difference there in household substance abuse. For divorce, pretty similar. Household mental illness, so about a quarter of women report household mental illness, and about 15% of men do. Mother treated violently, 13 and 11% respectively. And incarceration. Incarceration is one of the ACEs. We know that just simply having a parent incarcerated seems to play with the data and have more significant outcomes to the negative with the trauma. Because if you look at incarceration, it's just not that event, right? There's probably all these other tales attached to it. That abuse in the home, maybe drug use, negative peers or individuals in the home, those type of things. Moving your house all the time, going to new schools, CYFD involvement, etc. So this is kind of a really nice little graph here. It shows us the difference between mood disorders, anxiety disorders, substance abuse, and impulse control disorders. The impulse control disorders are like, the defiant child, things like that we see, not making choices without making choices without thinking through them. So if it's hard for you to see there, I think it's pretty good. But the red color is 1 ACE, the green color is 2 ACEs, the purple color is 3 ACEs, and the blue color is 4 ACEs. So we see the prevalence of the different issues. So with mood disorder, with 4 ACEs, we're seeing almost a 50% prevalence, half, okay? With anxiety disorders, with 4 or more, we're seeing 70%. These are people who are consistently locked in fight, flight, or freeze. They're terrified. They're hypervigilant, but that's how they live, and that's all they know. Can we help them? Yeah, it takes some time. They have to build trust, okay? But it's significant. Now, from those anxiety disorders, what do you think people do? Drink and smoke, right? Drink and use, right? Smoke and use. Do crime, you have no options, right? Can't go to a job every day. You're constantly anxious to that level, right? You have to find other ways to survive, right? Substance abuse, not quite as significant as anxiety disorders, but we see almost a 50%, looks like about 44 to 45% of substance abuse use. And I mean, let's go down to 2. So 20%, a little over 20% of people with 2 ACEs. So 2 ACEs could dictate 20% of the individuals having a substance abuse disorder. And we're not talking about the guy who has a couple extra drinks at the company party at Christmas. We're talking about significant substance abuse disorders, okay? Things that lose jobs, prevent jobs, cause health outcomes that are negative. This is what ACEs tells us with the data, okay? So we talk about traumatized kids. How does this get filtered for them, right? The world is punitive. It's humiliating. I'm scared, right? Everybody's judging me. This is a big one for me, the external versus not internal. This means that I can't control myself, only the world can control me. That's prison, right? That's an externalized experience. Kids that believe that they can manage their emotions and cause change in their daily life make those choices. They imbibe the ability to affect what's going on around them. But if you really believe that I have no control of what goes around me, then you are just reacting to everything, right? And that's why we see repeated issues, just repeated incarcerations, repeated drug use, repeated broken relationships. That's a big one for me, that idea of external versus internal control. And that's the message they get when they see their parents act in such a way, or when that trauma has happened to them. Dad got killed. I couldn't control that, so I guess I can't control what goes on with me. I'm just out there. And you'll hear those hopeless statements, right? I have no control. I can't fix anything. I'll just do the best I can. Protect myself the best I can. So again, another big one, people unpredictable and untrustworthy. Of course, that's the internalized value. That's the core belief that gets there. We can reframe that, and that can get healthy through good treatment, but that's what happens. We talk about fight, flight, or freeze, but did you ever have a kid or an adult just lie to you? Like, you know that they're lying and they just continue to lie to you, and you're like, why would somebody do that? Like, why would they put themselves in the situation where they know I know they know, but they're still not going to acknowledge something? It's because they can't. It's too terrifying, okay? They found that the truth is dangerous, and they have to hold on to that survival for whatever they can to get through that, okay? I know. So healthy relationships kind of go out the window. How do you form them? You don't see them. You know, maybe some of us had the opportunity to see really good husband and wife relationship, or partner relationship, or grandparent relationship, or whatever that case might be, something healthy. We learn from those relationships. We see that, right? We take that in, and that gets lost. So we don't have healthy connection, and we all know how important connection is for our brain. Then we lose a lot in our ability to manage stressful situations and to be healthy and not experience trauma, or be able to be resilient with trauma. Children's social skill learning is directly related to the characteristics of their environment, absolutely. Ask any kindergarten teacher, first grade teacher, what they see, and we can't say this for sure, but they could probably name which kid has a calm, safe home versus maybe not one, right? Unless we're dealing with some sort of cognitive issue or some other issue that might be present that's nobody's fault, so to speak. So violence teaches withdrawal, anxiety, distrust, overreaction, hypervigilance, and aggression. When I talk about violence, it doesn't mean somebody has to get punched in the face, right? Kids could see things getting broken, holes in the wall. Like, those type of things are aggressive, right? And that plays out in how they process those things. And it's impactful and long-lasting. I didn't hit her. You hear stuff like that. What did you do before that, right? And the kids are watching. Domestic violence is a huge problem. Disordered environments equal dysfunctional skills, of course. So what are the trends? ACEs are surprisingly common, right? I'm going to hand out the ACEs to you guys in a little bit. It is your copy. Nobody's going to look at it, but feel free to look at it. And if you want to look at it through a little looking glass self and see if there's anything there for you, that's fine. Just be aware it could trigger something, and make sure you have some support if that's the case. But I think it's important for you guys to see what these ACEs are. They're just 10, and they're pretty straightforward. Again, the dose-effect relationship, it's profound over the years. Transformed from social experiences into physical disease. And I think that's something I really want to hammer a little bit today, this idea of we're talking about people dying early, right? Liver disease, heart disease, whatever the case might be, suicide. The game is big here, right? It's just not about being depressed or unhappy, it's about life. And that's why this stuff is so important to me, okay? And our public health system, honestly. The strain that it puts on and how we can improve that and help people in more significant ways if resources were better allocated. So ACEs are a powerful determinant of health and social well-being in the nation. I'm not scaring you guys too much. I see a lot of scared faces out there. So again, just some more data on the, this is setting you up for the next slide, but a person with 4 more ACEs is 2.2 times likely to die of ischemic heart disease. That's one of the major killers. I think it's not the #1 killer in America. 2.4 times as likely to have a stroke, 1.9 times as likely to have cancer, and 1.6 times as likely to have diabetes. You know, those cancer, strokes, and diabetes, they're debilitating diseases. People might survive them for a while, but they're going to cause significant trauma within the family, right? Somebody's very sick, very ill for years at a time. So that's impactful. So this is what we're looking at. So this is a little triangle. Again, not to be too morose, but we need to understand this. So we have historical trauma at the bottom, right? We move into the social conditions that come from that, the local context. If you grow up in a poor neighborhood with not a lot of resources, like sometimes adults will talk about, hey, there was that one gym teacher, right? Or that guidance counselor or neighbor, Bob, who cared about me and talked to me a little bit. Sometimes that's all a kid needs, not to be perfect, but to get through those experiences. So they can divert from some of these layers here if there's different interventions, right? Maybe they got referred to a therapist, right? At the local context or the adverse childhood experiences level. But this goes on, their neurodevelopment is disrupted, right? What did Nadine Burke see? Dr. Burke, she saw ADHD. Everybody's getting referred for ADHD, right? And don't get me wrong, it's a real issue, but not, 25% of her patients, right? So that cognitive development, that cognitive neurodevelopment issues, thank you so much, is real. But it's real because it plays into the next stuff. There's impairment, right? Bad choices are made, right? Choices are made that are unhealthy. That's where it leads to them, okay? Adoption of high-risk behaviors. Long enough, depending if it's drinking, it takes a couple years. Depending if it's gang involvement, it could be tomorrow night. But then we have disease, disability, and social problems, right? Incarceration, etc. And then early death, okay? So Billy doesn't have any intervention. He sees mom and dad fighting all the time. Mom gets beaten up, right? He's not taken care of. He goes to a foster home. He comes back home. He's neglected and ignored. Nobody intervenes. His brain is making choices to survive. He's on fight or flight freeze all the time. His anxiety is through the roof. He's not going to be in, special classes, advanced classes. He's going to be the kid sitting back in the corner, quiet or causing trouble, right? Further relegated probably within the school system. Who does he seek out? People who will be with him. Who are those people? People surviving the same way, right? So then the Friday nights at 12 or 13, 14, 15 become drinking, right? Then you meet the gang members, so to speak, or then you meet the girlfriend and unhealthy choices are made, and so on and so forth. High-risk behaviors come into effect for Billy. And then we know the rates. If a kid is sitting in Dr. Burke's office, and we know what the trauma is, without intervention, we know what the percents look like for his life outcome. We know. On a grand scale, we know. So this is a little sad, but it's real. So this is cross generations, right? So a little bit of what I was just talking about, kind of preempting this a bit. At the top there, it's a little hard maybe to see in the black and the red. It says child abuse, some sort of form of child abuse, right? So what type of things do we see? Conduct problems, right? Before we see antisocial, we diagnose kids with conduct. Some kids don't get antisocial, but that's what we say, conduct disorder. Depression, PTSD, anxiety. And again, PTSD is always there. It's part of the symptomology, but it's the trauma that's fueling that. And then, of course, school problems. the way America's been set up is our schools are supposed to be the opportunity leveler for kids who are born into poverty or difficult situations to get themselves to another level, right? But if you're already coming in with trauma, how are you going to effectively access those resources in school to get those opportunities, to get that scholarship, or it's not going to happen. So this is very, very real, unfortunately. So in the adolescence, a lot of re-victimization. That's something big. So the kids that this happens to, we see put themselves in situations, again, where they're going to be victimized, whether it's sexual, physical assault, you name it. That's what happens, because that's what they know, and that's where they end up. Again, the depression continues, the anxiety continues. Then they start leaving the schools, and the schools are places where to catch some of these kids, right? Get them referred to the right people and that type of thing, depending on the resources of the school, what city, what state you're in. It's a big variance. But once they leave that, there's not much that's really going to intervene outside of the police in these kids' lives and adolescence. And then, of course, substance abuse. We're seeing it younger and younger for some of the really traumatized kids, but that always plays a role in adolescence, or often plays a role in adolescence. So as an adult, a lot of, maybe there's early pregnancy, early children. You see parenting issues. The generational trauma is continuing over again, right? Domestic violence, maternal depression, PTSD. If you're a mom and you're 21, dad's not there, the man's not there, you're living, just trying to survive, you're depressed, right? Things aren't good, and that translates to the baby and all those outcomes. And we all know that, America's not the best in natal outcomes compared to some other first world countries, so these things play a role even at that level. Of course, poverty, and then of course substance abuse continues. And then we have the child abuse again. So that child grows up, experiences similar things, and this chart starts over again. But let's talk about treatment, right? So without getting into all the details, TFCBT, and it's been mentioned this a couple of times at this conference, really can be impactful, right? People are specially trained in this dynamic, and they can really work with the children and adolescents and make some differences. This is so cool to me. Children with 4 or more ACEs respond as well to treatment as children with fewer ACEs. It's cool. That's what the data shows. So if you get them in the dynamic of treatment, you have the opportunity for them to see that, you can see real gains. So the dose-response relationship doesn't play here, which is cool. Therapists who follow the guidelines carefully get the best results. So that's talking about the CPP or the PCIT or the TFCBT. If you follow the validity of what that program is trying to teach, it makes a difference. If you vary, you go offline, it's not as effective, okay? This is cool too. These treatments affect the kids, but also the parents if they're engaged, right? It improves their own mental health. And then this is also very cool. It can restore normal biology. So you don't have to worry about your back all the time. You don't have to feel like you fight, flight, or freeze all the time. The hypervigilance reduces, right? Maybe secure attachment can happen. Maybe trust can increase. So it's possible with treatment. It's here. The data shows us. So what are the components? These are just the 3 main components of, in this case, trauma-informed care. Creating a safe environment, building relationships and connectedness, and supporting and teaching emotion regulation. Emotion regulation is huge. Again, going back to my kindergarten example, kids are learning that when they go to kindergarten, but they're all coming from different environments, right? And some kids might have different experiences with how to regulate themselves, and it's usually modeled by the parents. So you can really then tell what kid has some emotion regulation or needs to learn some emotion regulation, right? But that dysregulation is real. It's okay to be dysregulated sometimes. It's about how you manage it and how you deal with it and overcoming it. So when we can teach kids to be able to manage stress in a healthy way, we see outcomes improve, right? We teach adults the same thing. We see outcomes improve. So much of this is trying to get away from something. When people have trauma, it's always about getting away from something, avoidance. How do I get away from? I'll use drugs, I'll numb out, right? Hang with the gang, at least they like me, at least I'm connected with them, right? If I go to prison, oh well, at least I have 3 meals a day. I can sleep somewhere because I didn't have that before. This stuff teaches you how to manage it. I'm not going to avoid it, I'm going to deal with that feeling. The ability to sit with discomfort is something I try to teach from the worried well all the way through the individuals with serious mental illness. How can I sit with a feeling that I don't like in an effective way and move through that, right? And there's ways to do that. And I'm going to teach you one today. And then, of course, connections. So important. Our brains are built for it. We know that. We can talk about the hunter-gatherer societies and how we survived and all these different things about where that came from and our biology developed because we needed each other to survive, honestly, to raise children. You know, this is not a 100-year game. We're talking about evolutionary stuff, how we manage ourselves. So when we connect with other individuals in a healthy, profound way, our whole mental health improves. And when you're cut off and hypervigilant and afraid of the world, you can't have really good connections. So when you can build connections, healthy connections, it makes a difference. Offhand, we know that retirees, right? It's always that people say, oh, they retired and they died, right? You know, not to get into the data, but we know that individuals, when they retire and they have a couple healthy connections, a couple healthy relationships, they live much longer. Isn't that cool? Just having that ability to have other people in your life that's significant, whether it's a friend or a family member, really improves our mental health. Same thing with those who have trauma. So what more can we do just from kind of a public health perspective? We've got to screen for ACEs more. You know, we got to do it in prisons. We got to do it in mental health care. We have to do it in schools. We have to do it. I think eventually you're going to see it happen in pediatrician offices pretty consistently. Some are doing it, but I think we're going to start seeing that as more mental health dollars hopefully flow into the system and best practices of care become stronger. We're going to see that, I believe. Building capacity to prevent and treat child trauma, and just more people that know what they're doing with it, how we manage it, how do we identify it, how do we get them where they need to go, right? Again, it comes down to money oftentimes. Trauma-informed services for children and families. The family context is huge. We fix the family, we fix the community. Integrating and enhancing programs to target synergistic ACEs. So what this is talking about, I didn't get into it today, is we know with some of the data that certain types of ACEs that pop up for a child play more profoundly with others. So for example, I think domestic violence and substance abuse in the home create a bigger issue than, say, just poverty, okay? So there's a synergy there. So that's what that's talking about. And then integrating trauma services across family serving systems, in which a lot of them are trying to do that or are doing that. So the protective factors that we see in resilience is strengths-based approach to supporting children, natural supports, the village, the good neighbor, the coach at soccer, something along those lines. Treatment support advocacy, and then skills building related to self-advocacy, education, and empowerment. We want to work from a needs-based, not a problem. So we're working on this because this is something that's helpful for you. It's not because you're deficit somewhere. That's got to be the message. Okay, well, it's 10:43. I'm going to hand out the ACEs so at least you have that. And then I'm going to give you opportunity for some questions. Can you hand those? Just one sheet, it's on the front and back. These are two helpful things I've used with a lot of people. Progressive muscle relaxation could be a bunch of different stuff. But basically, it is a script of tension and release from your head to your toes, so to speak, that helps you manage and ground yourself. It's longer, a little bit more entailed. Then I have the 5-4-3-2-1. The 5-4-3-2-1 is a cool grounding technique. It comes out of the DBT realm, but it also grounds you. And what it does is use your senses, right? So 5 things you see, 4 things you feel, things you see, smell, feel, taste in your environment, and that helps ground you. It's a quick and dirty tool. I use it with a lot of patients, and it helps in the moment to kind of ground people. I was going to do it with you guys, but I don't think we have the time, but I just wanted to mention it. Questions? Thoughts? Don't go too sad to lunch.
It's very eye-opening. I mean, I think when most people think about trauma, it's really not preventative. It's, okay, well, now we have all these adults, and they have all these severe mental illness, concerns, or they're really just struggling in adulthood. So how do we fix that now?
Yeah.
And just learning about that, and I think getting the schools and particularly pediatricians involved in screening for those ACEs, I think is going to be the key, because trauma is just a huge problem.
Yeah, it is. And I think it underlies so much of what we do in our different fields, whether you're in education, whether you're in therapy, whatever the case, a state serving system, it really propels a lot of that. So yeah, we're here to pick up some of the pieces of trauma, and we would love to get to the point where we can start preventing some of it by doing some of those screenings. And maybe a kid comes in at 12 or 10 and he has 1 ACE. Comes in next year, he's got 4 ACEs. We know what that data looks like, right? But if we can see the 1 or 2 ACEs and there's a problem there, we can help fix that. He doesn't get to the 4 ACEs. And then maybe he lives longer. I mean, it's significant.
Yeah, because these kids are not going to divulge themselves if they're experiencing trauma at home.
Oh.
So I think teaching, especially educators, the signs and symptoms to look out for trauma is so important so they can make referrals to the school counselor or whatever.
Absolutely. And really being in that pathway of you can tell me. It's okay to talk about it. Yeah. Cool. Well, thanks for coming, guys. I hope you enjoyed it. Have a great day and enjoy your lunch, I think. Maybe another hour, 2 hours, sorry.